Okay, and now we are going to welcome Wiese, who's going to talk about her research next. And I think we'll go about 10 minutes into our break. The price of having fascinating conversations and presentations is that we must be kind of away from our break. And welcome.
Everybody can stand up. We've been sitting there, right? The smartwatch is worn off, so let's all stand up, stretch a little bit. Yeah,
Love it.
march and play.
So good.
Yeah.
Yeah, I'm gonna need like stretch.
Get the blood flowing again. With my students, I do Simon Says, so Bob's very bad. But anyway, okay, so this could be more planned, more better. I'm so grateful to Dr. Kusevich and team for inviting me. It goes perfectly with what we just heard from Dr. Rivera. The invitation came because of this article. I was blessed to be first of 45 authors on global rural health disparities in Alzheimer's disease and related dementia. Say the science that appeared in Alzheimer's dementia last May. And I really want to give a special shout out to the Alzheimer's Association International Conference Diversity and Disparities Group, who had the vision to ask me to start the Rural Health Disparities Work Group. So it's really been exciting. So we've heard from a couple of people, starting with Dr. Carter yesterday, and mentioned again this morning about the importance of location. So in rural, for a while we were all trying to decide on a common definition of rural, and this paper talked about how that's really not the best idea. We suggest a continuum based on factors, and I'm not going to go over all those factors now. We've heard a lot about it today, but rather than a dichotomy, it's a blend. I love hearing Dr. Kusevich talk about explanatory models for all these variables, 3 different ways of looking at it, and also Dr. Garibach and Dr. Chen yesterday looking at how we would offer a decomposition of those variables, because it gets to the point that several of you brought out this morning is it's more than just race ethnicity, it's about culture. And that picture, by the way, was one I took in the Glades. So talking about burden in rural areas, so no surprise, there's a lot more. I will point out that globally, 20% of older adults in the European Union reside in rural areas compared to 42%. That's quite a bit higher than our area. But all of us deal with this lower middle income country. I could tell you the population that I work with, which I'll talk about in a little bit, they would be considered a low middle income country. They're all around Lake Okeechobee, a cohort there. And also, rural counties comprise the majority, 84% of counties designated as older age counties. Okay, so rural is a factor. It's more people are living longer, moving there. So this is a picture of community sugarcane burning in the area I work in, which is South Central Florida. There's a big farming area, lots of vegetables, but also lots of sugarcane. And that's what you see here, burning a sugarcane burn. And we were blessed with a R01 over the cap in September to look at the impact of sugarcane burn, lack of built environment, and social isolation on dementia risk in this community. And they're 91% racially, ethnically diverse, Hispanic, Afro-Caribbean, which is classified along with Blacks. And again, it's a whole different culture. In fact, they don't even like each other. So it becomes an issue, okay, when you're trying to deal with these folks. And Hispanics, 29%, but African Americans by large, almost 60%. So what are they looking at? So we do see lower survival rate, post-rate diagnosis of rural settings, but also lower prevalence, is what we've been seeing. And it's fascinating to hear your talk on the Medicare data, because I do think it comes down to culture. And fortunately, yes, as pointed out, much of what we know is about from weird communities, right? Western educated, there's a lot of rich democratic samples. So it really is an issue. We do need to look at that community-based approach. I just did a paper with community-based research and ADRD burden. I encourage you to look that up because rural residents are at least twice as likely than urban dwellers to get all these chronic illnesses that we've been hearing about, the exposure I'm talking about from burn smoke, obesity, alcohol use, such on all the factors that Livingston talks about in the risk factors for Alzheimer's disease and related dementias. So, depression, I mentioned social engagement. I work in ADRD prevention, all three levels, primary, secondary, and tertiary. I'm amazed by the number of folks that I work with in my cohort who want to address these. They're showing up for studies. So we've done 4 federally funded studies there now. Work with Dr. Jim Galvin on the BCID study, we're collecting saliva samples out there. Of course, we are finding prevalence of vascular dementia to HRSA grants to bring students to rural areas to work to the KL1 and R1 from NIA. That's how this has all come about. And it's based on a couple of things. One is my philosophy of nursing based on a theoretical framework by Wood and Schoenfer called Nursing is Caring. And the key thing is what matters most. And that was long before this started coming out as a buzzword recently with insurance companies and grants and things like that. But authentic presence, determining what's in the in-between, beyond what you can see, things like that. So we applied the NIMHD framework that you see here. Most of you probably know this by now. And we came up with this model that's in the article to look at it from the viewpoint of barriers and facilitators and individual, interpersonal, community, and societal factors. So for example, if you look at individual factors, it goes from alcohol misuse to culturally adapted interventions being on the positive side. And then interpersonal factors could be something as simple as caregiver challenges or mistrust with providers to intergenerational connections on the positive side. I will give a shout out. We have a 211 system. There's not a whole lot that's good in Florida right now by diversity and equity, in case you've noticed. But we do have sunshine calls to our older adults where you can arrange, they can get a call once a day and talk with someone. So, depending on what you have in your area. And the community and societal factors, no surprise, transportation is a big one. Lack of built environments. We have no bowling alleys, no movie theaters, no coffee shops in the area that I'm working. So how do these people get socially engaged? So you'll see that churches are a big thing here. Okay, so that's something. That's what I've done. I've applied Nancy Schoenberg's model from University of Kentucky, Faith Moves Mountains, made a huge difference in Kentucky with increasing detection, diagnosis, and management of cancer, cervical cancer, prostate cancer, smoking, and she partnered with me on my work here in McGlades. And then for the article, Amy Nelson, I have to give a shout out to her, came up with applying this term location dynamics and define it as an individual, their interpersonal relationships, community, and society characterize the place where they live. And the intersections of these dimensions, which we heard about from Dr. Rivera, impact the individual, hence location dynamics. So you have the different protective and risk factors on all these other things, environments, behaviors, health services. So this is the model we came up with that's in the article. And I gave you, I'm a nursing professor, by trade. So I gave you a handout because I found that, if you take away something and you talk to someone, about this, it's always good to have something concrete. And I realized as I've been hearing these amazing talks the last few days, that you could even do this with secondary data analysis, where you're looking at what are your particular community and society factors, those interpersonal factors that are impacting your location, okay, your specific thing that you are trying to look at. And then what are the protective or risk factors? And ultimately, you want to get to where you are decreasing the burden. That's your outcomes, right? Is to decrease the burden. So I encourage you, when you're bored, listen to me, whatever, play around with it, but take it back. Ask your RA to talk to your community advisory board. As Dr. Rivera pointed out, we shouldn't be doing any work at the ground level without a community-led effort. I mean, I just wouldn't do anything. We meet once a week faithfully for years with all our community stakeholders and navigators, and that makes a huge difference. So here's that model that I was talking about. So again, the outcome is you want that decreased burden. So I had a student who did that. I could improve on a little, but basically your first step is to list the factors, as I said, plot your other factors along the line, and then get to your green. The key point here is a lot of these factors could be barriers or facilitators depending on where you live. That's why it's so important to be cultural specific, location specific. Okay, so with community stakeholders, do a SWOT analysis, summarize them, identify factors for your model. This is sugarcane burn on fire. And I'm going to stop and talk about this for a minute. When you burn, so to cut cane, it's a lot easier to cut it if it's burnt. Okay, so the problem is it releases PM 2.5 into the atmosphere. It's the same that we get with auto exhaust, wildfires, sugarcane burn. These are people who are working in this 9 months a year. Now, big sugar, that's what we call, Dixie Christmas and all that. They say, well, we only burn over here for, 1 day and then not the rest of the year. And then we burn over here 1 day and not the rest of the year. So it's really not an issue. Well, the problem is the smoke and the wind. So it's a well-known fact that the smoke is going east, meaning over to the coast, which is Palm Beach County, which is Mar-a-Lago. 54 billionaires live in Palm Beach. Okay, I'll show you on the map. You head straight out 80, 52 miles, and you run into the poorest town in the state of Florida, which is where we do the majority of our work, Belle Glade, Florida. So the smoke's going to the coast, forget it. They don't burn. They will burn north, south, west. Okay, so these people are exposed all the time. So anyway, you want to, getting back to this location dynamics model, you get one factor to investigate. You get the stakeholders to identify what might work and what might not, and then you share it with other leaders. So we've done all kinds of things, ranging from water distribution there's been terrible water issues in Lake Okeechobee. I don't know if you heard about, the algae blooms and all that. Not so much drinking it, but inhaling it. But people had this perception. What mattered most to them was drinking clean water. So we had initiatives for that. This is robotic cut therapy. One of my students did it for the people who were socially isolated during the pandemic. So you really want to always be working with your community leaders. And we hire people in the community to be our research assistants. They get trained to consent, collect data, do the interventions, follow up with people and report back to us. That is the only way that we could ever do any work there. This includes saliva collection now for Jim's study, Dr. Galvin's study. I would love to do blood biomarkers. I've been paying big attention to Dr. Milky and Dr. Matt talking about the importance of that, but also ethics, right? Because what are you going to do with it once you do those samples? And also you want to evaluate and be at the right time. I showed this to junior researchers. By the time I got to the right place at the right time, I was the wrong age. So I am 67. I'm needing to retire. Well, I just attended Impact AD. I need to do a clinical trial, right? So I'm encouraging all these young people to get involved and get out. Now, so in our R01. We are going to be looking at using GLMM to examine the effect modification, with these factors through cross-level interactions. So we're going to account for variance in the outcomes across neighborhoods. We're going to look at, like I said, built environment, also social isolation. We have an AIM 3 actually that's using wearable technology, smartwatch use, along with Diane Cook from Washington State. We did a pilot study there. That's another thing. We talked about access. This area still has in the 50s for digital access and literacy. So they just don't have computers. I did a pilot study, huge success. They want more. We took high school students, trained the older adults how to use Chromebooks that we supplied through grant, and then they were able to get on to Cherry Open. And that chair yoga effort has been sustained. This is the thing I'm most proud of in our communities. It's been sustained now by local, regional, and state funding since we did it. But anyway, so if you want to think about taking a location dynamics model and making it work statistically, I highly recommend this GLMM. We also looked at linear trajectories. We're going to use multi-level linear growth modeling and look at time varying factors. So we're going to look at the fixed effects of community into prediction models to control for those factors. So it's going to be very, neighborhood specific. We're looking at 5 towns around the lake and 1 in an urban area with similar race ethnicity to compare. So we do have a lot of limitations. We didn't look at physical ability. Health literacy is a big issue there. The majority of people that we work with use in the realm, the rapid estimated adult literacy medicine short form, the average reading level is 3rd or 4th grade. These are people who didn't go to more than 7 or 8 years of school. So that's a big factor. Another big factor is the incidence of chronic illnesses like diabetes and hypertension, but also asthma. The local hospital did a community needs assessment. Asthma was the #1 concern. People are, their children are going outside to play during the sugarcane burns. They've learned they can't do that. We distributed 9,695 masks last year as an answer to what matters most to this community. So there's a lot of issues going on. One thing that I will tell you is they love education. They want to know what the difference between Alzheimer's and dementia is, right? How many times we get that question? So I use this to start explaining. I was unfaithful to you once with some redhead in the men's room of pool hall in 1971. I was drunk. That was me. So that's a perfect explanation difference between vascular and Alzheimer's dementia, right? So they want to know, they want to do something that's going to help them age in place and avoid medical bills. One of the things that we have done that's been most successful is we bring along the Diabetes Coalition in everything we do. Everybody out there has diabetes and hypertension. I'm not kidding. It's amazing, the rates in the 90s. So we bring the Diabetes Coalition, people come and get their A1C checked, then they come and get their high blood pressure checked, and then we do more education with these students I mentioned to talk about why they need to be taking their medication. They have it, they've got it at home, they're not taking it. Then we talk about chronic kidney disease, which we heard from Dr. Melke is a big factor now. They're just working with the community to find out again what matters most is so important. I will say that addressing the issue from a neuropsychologist point of view, that's so important. We're using Jim Galvin's number symbol coding test. It's language neutral. It's a row of 10 figures, 10 symbols. They have a key at the top, and they have to fill in the missing blanks up here and get to, a certain cutoff. Our problem was the cutoff was based on the weird sample. So now he's looking at, we've done about 400 people, I think, and he did a bunch of people down in the South Pacific somewhere. And we're looking at what the new cutoff is going to be. But there is some hope. There are some measures out there. We're using the mini MOCA. So the mini MOCA is, recall 5 words, name as many words as you can to start with the letter T in a minute, and orientation. And we have had to eliminate people in the African American community who never learn to read or spell. So what do you do with those 10 words, right? So it is really an issue that cultural divide in cognitive screening, even not just assessment. So these are keys I already talked about. They're going right along with what Dr. Verment noted, so I won't dwell on that. But yeah, strengths and barriers. These are pictures from the Glades. So again, work with your leaders in the local agencies and create neighborhood ambassadors. That was one other thing. Something new I didn't hear today is we have pockets of neighborhoods within the communities. And so we've organized neighborhood ambassadors. We give them handheld flyers about the things that are going on, about the food banks, about the next health fair, about their little walking clubs that they started, what's going on. But when hurricanes come, that's a big deal for us in South Florida. we use these neighborhood ambassadors, so that's been really helpful. So using geospatial analysis is imperative. Looking at on the ground measures, providing earplugs and blackout curtains for most sleep. How many of y'all had a good night's sleep here last night? Okay, beds are amazing, right?
Yeah.
So if you can, anyway, none of us get enough sleep. That's an issue, right? We need to get more sleep. Okay, so empower residents to create their own definition of health. Ask them, what does healthy mean to me? In Appalachia, it was about being able to go to work every day. It didn't matter how many comorbidities they had. I'm from West Virginia. So access a rural health information hub. It's not used enough. You're going to look at rural areas. Please tap into that site. It's amazing. And building culturally specific beliefs and practices as a first component in writing any health promotion and disease prevention plan of care is essential. Okay. And so these are just pictures of some of our folks. Those are some of the citations, and thank you very much.
Okay, we have time for a few questions.
Yes, sir.
Thank you for this nice presentation and to pointing to several things. From one point of view, is the external environment, is a physical, social, economic, and on the other side is the individual level perception and so on. And the model, it seems that should meet or somehow match the environment and the individual.
Yeah,
And my question or
comment.
how the models can match these two things and where the individuals live in and how is it predicted? Because individuals living now and in 100 years are different.
Yes, that's right. Yeah, that's a great point. Actually, we are looking at the blending in the R01. We have a model that blends those individual factors with the environmental factors, and I'm happy to share that with you. Yeah, because that's exactly what we're trying to do. Yeah, I could have included it on this slide, but it's a bit tricky. I encourage you to talk to our statistician. I love having a statistician on our grant. It's so important. But yeah, that's what we're doing, is we're trying to mesh the two. Because it is so important, the environmental piece is so important to the individual level factor. Yeah, thank you for that.